happy National Cholesterol Education Month. It's designated in September. We're here to talk about something Dr. Willard and I have been pretty passionately talking about in the last few months and in different projects about prescribing with purpose um, and really we have the Hippocratic Oath, right? Do no harm, but now we need to really reflect on doing the most good for patients. We have so many tools, so many different medications to choose from now that we have to scrutinize our decisions, right? To make sure we're picking a medication that is not only helping what we're treating, but not altering or harming another comorbidity of the patient. And there's a lot to it. So we're going to talk about that today. My, my name is Beth Jackson. As you see, I am a clinical nurse specialist. I've been a lipid specialist for almost 20 years and in cardiology for over 25 years. Prevention has become my passion. I focus on lipids and cardiometabolic issues and lifestyle medicine. I am very happy to be here with Dr. Kaye-Eileen Willard and very honored to serve on projects with her in the last few years and be here with you today. So Dr. Willard, I'll pass it to you.
Thank you very much, Beth. Well, as you said, and I have no disclosures, and neither does Beth. So we can move to the next slide. We're here today to talk about cholesterol management, but also a discussion of the complexity of the modern patient. I think we all recognize that our patients are getting sicker and they're living longer because we have so many tools available to us. But by the same token, they're also now faced with dealing with many comorbidities. So even though we are lipid specialists and we're treating the lipid disorders, we have to be very aware of all of the risk-enhancing factors that also play into cardiovascular disease, including hypertension, diabetes, obesity, and many others. So our discussion agenda today is going to really focus on the complexity of modern healthcare. And as Beth said, our guiding principle in medicine has always been primum non nocere, or at first do no harm. But now, in the face of addressing patients who have so many active medical conditions, when we do get past our initial phases of lifestyle management and we've risk stratified a patient to the point where we know that they need and will benefit by medications, how do we do that most appropriately? So we'll address those issues as well as discuss some of the barriers to doing this, of which there are many. Focus on doing the most good. There are no perfect solutions, but we do have guidelines available to us. And then we're going to present a patient that's probably going to be familiar to everyone listening to this call, because we see this type of patient on a daily basis. Next slide. When I looked at this slide, it reminded me of the American Heart Association's Essential 8, which is basically those essential 8 categories of modern life that we need to adhere to in order to promote health. We at the National Lipid Association, of course, are very intentional about prevention of cardiovascular disease, but we also want to optimize health in general. And that means recognizing all of the potential interactions between what you see on the screen here. We have people who, because of either social determinants of health or lack of health literacy, have a poor diet. They're sedentary, maybe their job necessitates them to be inactive. They may have genetic profiles that predispose them to cardiovascular disease, dyslipidemia, diabetes, hypertension, and so on. And of course, smoking is always a factor that we still have to address. So if we look at this from the standpoint of medications, as shown on the slide here, in type 2 diabetes, there are about 14 drug classes, not including insulin. Hypertension, we have even more, 218 high blood pressure prescription possibilities across multiple different classes. When we're treating lipids, we have a great deal more available to us now than we did even 10 years ago. Looking at cardiovascular disease, there are, as indicated on here, almost 4,000 distinct cardiovascular drugs. And when we're looking at this all occurring in the patient with obesity, we have additional FDA-approved prescription drugs that address those issues. So how do we make intelligent selections in a shared decision-making kind of manner with our patients? Next slide. We've divided this discussion to look at barriers into several domains: the patient, the healthcare systems, providers, our treatment modalities, and our social determinants. And I'm not going to read through the whole slide here, but we've already mentioned a few: low health literacy. In terms of system issues, we have limited access, fragmented care. Often patients see multiple different physicians. They may have long wait times in order to get in to see their clinicians. In terms of the provider, their visits are short, and they are obliged to be addressing so many different factors in a short period of time. They also have to be very alert to the polypharmacy concerns, because many of our patients, as we all know, are seeing multiple specialists. On the treatment side of things, we first of all have to consider the number of pills that patients are taking, what the drug-drug interactions are, the fact that frequent monitoring is necessary. And then another very challenging area that we're just going to touch on a little bit today is the whole issue of insurance coverage, health plan coverage, and prior authorizations. And finally, we know that social determinants of health are a huge factor in terms of providing equity in healthcare. Some of the disparities in social circumstances, even including drug plans and insurance plans, are really different between different groups, cohorts within the population. Next slide. So now I'm going to turn it back to Beth, and she's going to present our patient, Mr. P.
Mr. P, I think you all probably do know him, and he hits on many of those barriers in Central Texas, rural Texas. He is 58 years old, married with 3 children, and is originally from Mexico City, but has been in the US for a long time. His dad did pass away of an MI at age 67 and mom at 71 of breast cancer. He did go to the ER about 4 years ago and was having chest pain. He ruled out and was sent home to follow up with a cardiologist or his primary care, more likely his primary care. And he was given a prescription for atorvastatin at that time. He quit smoking because he had a scare, but no workup ended up being done. His BMI is 38. He is inactive and he filed for disability because of chronic low back pain, and he had a previous career in welding. He follows a traditional Mexican dietary pattern. He does not currently have chest pain. He does have some dyspnea on exertion, and he's very sedentary and overweight. He gets tachy palpitations at times and has trace edema. His diagnoses on no current medications include stage 2 hypertension, and we're going to dig in deeper on these. He's consistently, now that he's re-engaging back in the healthcare system, consistently getting 140s to 150s over 80s. Again, his BMI is high. Diabetes, A1C is 7.6. He said, I've been told I'm diabetic before, but I don't like the medications and I don't want to go on insulin. And that's about the time he stopped seeking healthcare. He's got mixed dyslipidemia, and you can see here the total cholesterol of 250, triglycerides 255, HDL 32, LDL cholesterol of 167. And as you see here, he stopped his atorvastatin just 2 or 3 months after it was prescribed, citing intolerance. And then his LPA is 246 nanomoles per liter, and we are going to circle back around to that in a few minutes. He's got chronic kidney disease, stage 3A, with an estimated glomerular filtration rate of 52 and mildly elevated liver function tests. All right, so you guys know this person, right? I can picture at least 5 in my head. So let's drill into his mixed dyslipidemia a minute. His total cholesterol is 250, and we're like, okay, that's pretty high. We see a very clear pattern of diabetic the clear diabetic pattern here with the high triglycerides and low HDL cholesterol. And the LDL-C at 167, given a higher triglyceride level, we know can be discordant. The LPA is here as well. We're gonna circle back around, but we could do these advanced lipid testing, and they're valuable in some patients. It gives us a lot more information, but we do have more information than we're seeing here. And I'm going to tell you why. So whenever I see a high triglyceride, low HDL pattern, if I don't know they're diabetic, I start thinking diabetes, insulin resistance at least. And I look at the LDL-C and I say, well, let's figure out what the non-HDL is. So total cholesterol minus HDL is 218. So that's very high. Non-HDL, the cutoff point for the general public, 130, is where it usually gets flagged. For him, you're going to see in a minute with the guidelines that we currently have, we even want it lower. And with the non-HDL of 218, we can his ApoB is likely greater than 140, and the cutoff for a high-risk patient is under 80. And then remnants, we can see these remnant cholesterols. This is the cholesterol that's carried in very low density lipoprotein, intermediate density lipoprotein, chylomicrons that aren't included specifically in the lipid panel, but total cholesterol minus LDL cholesterol minus HDL cholesterol gives us 51. And the cutoff for high risk patients is 30. So he's got very pro-atherogenic lipid panel.
So Beth, I was also just going to say, we always focus on LDL cholesterol as our target in terms of addressing the risk of developing atherogenic plaque. But what we also have to realize is those remnant lipoproteins, the cholesterol carried in the triglyceride-rich lipoproteins other than LDL and HDL, are also extremely important and have the potential to generate plaque.
Very pro-atherogenic. Yes, thank you for highlighting that. Okay. So this is a snapshot. This is a paper that Dr. Willard and I both worked on, LDL cholesterol management simplified. And we know there's nothing simple about this, as we've already pointed out. But these are two sections of the paper. The right side is the statinisms that kind of talk about the different problems with statins. We'll come back to that. But we risk categorize our patients. And this top one is for very high risk individuals. And those are patients that have had an ASCVD event and have two other high risk conditions. There's a typo in there. And anybody that's referred to me that's come from the cath lab almost assuredly fall into this very high risk category. And I'm going to put a caveat in here too. ESC just updated their guidelines. Ours are being rewritten or updated as we speak. And so this is going to have a major overhaul because I'll give you a little bit of feedback on what the ESC did as we go. So high risk individual, this is where Mr. P falls. Anyone who has type 2 diabetes is a high risk and a candidate for statin therapy or lipid lowering therapy. This is where the ESC is going. It's got a lot of depth in their updated guidelines, and so I'm not going to address those specifically today, but I highly recommend a review of them, and it'll give you a taste of maybe what's to come here. So he's type 2 diabetic. We don't have a calcium score on him. We could definitely consider that, and it's something I would consider to get an anatomical study to see burden of calcified plaque, as well as we'd consider a functional study, right, with a stress test or similar. He does not have any known clinical ASCVD, and the primary prevention patient with an estimated 10-year risk of greater than or equal to 20% in pooled cohort. So I ran his numbers through the prevent calculation, and he is about 22%. So he's got two of those risk assessment factors that qualify him to want to get an LDL lower than 70, the threshold of 70. And then this is an FH patient here, just to comment on this, and an intermediate risk. And so without ASCVD, our LDL objective is less than 100. So the he took atorvastatin 40. We'd have to drill down with him on that a little bit more, get more information. Oftentimes, oh, my hairdresser told me that they're horrible, so I stopped it, or is it really a true intolerance? And so if our first step is to try a different statin, lower dose of the same statin or a different statin, and that might be changing him from a lipophilic statin, such as atorvastatin, to a hydrophilic statin, such as rosuvastatin. And a lot of times we'll get benefit there. Partial statin intolerance is when they can't take the dose that's going to reach the threshold that we're trying to achieve with them. And so strategies there, changing statins, adding non-statin therapies, and we're going to see impactful information here in a moment on adding non-statin therapies. We have really good tools, but truly an estimate of less than 5% are truly completely statin intolerant. And so it takes time, it takes discussion with the patients. There's lots of barriers there, as Dr. Willard had addressed earlier. And the very high risk patients or high risk patients, we can be creative. It's not high intensity statin or nothing. We can get very creative. Intermittent dosing, the longer half-life statins, there's good efficacy on dosing 2 to 3 times a week if you have to, but then the add-on non-statins are important. Okay. So
What I was also, Beth, going to add about this is, if you go back to that slide, this is an infographic that's available to clinicians because we published it as part of our Simplifying LDL Management in the JCL. So this is a really nice risk stratification tool where we can sit down with a patient. It actually is designed to be paper and pencil and have a shared decision-making discussion with the patient to help them understand their risks as well as what our potentials for therapy are.
So available to everybody. Yeah. There's a link to it on lipid.org, I believe, correct?
Mm-hmm.
Okay. So this is straight from the European Society of Cardiology. I really like this slide. So we're looking at the average LDL-C reduction in percentage. So the moderate intensity to the high intensity statin, and as you know, the high intensity statins are rosuvastatin 40 and 20, rosuvastatin 40 and 20, and atorvastatin 40 and 80. Those are the only 4 doses that qualify for high intensity statin that's available today. The EZE is ezetimibe. If you give monotherapy with ezetimibe, about a 20% reduction in LDL. And BA is bempedoic acid, and that's about 23%. So when you combine those 2 non-statins, it's about 38%. And you can follow it across. We've got, a lot of patients on high-intensity statin plus ezetimibe, and that's a 60% average, or high-intensity statin plus bempedoic acid, is 58%. And if you combine all 3, we're going to 68% on average. Then you've got the monoclonal antibodies, very robust drops in LDL cholesterol, around 60%, and that's as monotherapy. So adding on to the PCSK9s, and this is evolocumab and alirocumab, adding ezetimibe 70%, the 2 non-statin oral medications that are listed here, ezetimibe and bempedoic acid, 75%, and then if we combine the high intensity statin and the PCSK9, 75%. And you can see from there 80%, and then adding all 4, 86%. So I didn't mean to go through all those numbers really fast, but our point here is we can be very creative in achieving goals of therapy because we're going to want about a 60% reduction for Mr. P. And the way we get there is very good.
I was just going to add, Beth, and I'm sure you do the same thing, that when we're talking to patients about adding medications, I always try to emphasize we're not just making the numbers look pretty, that we are actually changing the pathophysiology of the disease and stabilizing plaque. So we want to achieve a specific goal, but in doing that, we're really changing the underlying natural history of the disease process.
That's such a very good point. I'm so glad you mentioned that because atherosclerosis is such a it silently builds and accumulates in our arterial walls. The LDL and the remnants cross into the arterial walls, become oxidized, trigger inflammatory cascade. We don't know this is all happening, but all of these mechanisms of treatment mechanisms impact that and impact the trajectory of your patient. Thank you. All right, I'm actually going to hand it back over to you to discuss the lipoprotein(a). Thank you, Dr. Willard.
Well, lipoprotein(a) is probably something I hope everyone has on this call has heard about. Clearly an area of a massive amount of research because we've recognized that lipoprotein(a), as it's known, is a very prominent factor in premature development of cardiovascular disease. And largely that's because it is a prothrombotic version of an LDL particle. So it is genetic. About 20% of average US and Canadian populations have an elevation of lipoprotein(a). Essentially, the way I always describe the structure of Lp(a) as far as relating it to its pathology or pathogenesis is the fact that it is an LDL particle that is mutated or has attained a variation where there is an attached little chemical tail called apolipoprotein(a). And that little chemical tail is very similar to a blood clotting agent that we all have naturally, which is called plasminogen. And essentially is, it's important if we cut ourselves or have small amounts of bleeding that we have inherent mechanisms to stop that kind of bleeding. So, and plasminogen affords that to us. The apolipoprotein(a) is an analog to the plasminogen. So essentially, you're taking a little chemical chain that's bound by a disulfide bond to the LDL particle. LDL, we already know, is atherogenic. We're adding to that this little tail that chemically promotes thrombosis because that's what plasminogen-like molecules do. And when we have an excessive amount of this lipoprotein(a), it accelerates risks substantially. So there are two different ways of measuring lipoprotein(a). One is in milligrams per deciliter, the other is in nanomoles per liter. For the most part, most of our laboratories use nanomoles per liter in the States. Low-risk individuals may have a completely normal or less than 75 nanomole per liter Lp(a). When we get into the higher ranges, we can categorize them as either intermediate or high risk. And those high-risk individuals are those with an Lp(a) level of greater than 125 nanomoles per liter. We're encouraging all of our clinical colleagues to check lipoprotein(a), and everyone deserves one to have their Lp(a) checked once in their life. And there's going to be much more to come on this particular molecule in the weeks and months to come.
Okay, so
Beth, do you want to go through our optimized?
Yeah, we can tag team it for sure. And that was a really great discussion of lipoprotein(a), and all of our patients do deserve that getting checked at least once in their adult life.
We have to train our clinician colleagues to be thinking about it.
Yeah, the conversation is gonna keep getting louder the closer we get to treatment options for it, but it definitely changes the discussion with the patient even today. So when we talk about customizing lipid-lowering therapy for Mr. P, obviously statins are first-line therapy. Lowering the LDL, we talked about the efficacy there. They impact triglycerides and they can raise HDL modestly. I gave it a yellow check mark because we have to drill down with Mr. P a little bit more and understand why he stopped it. And perhaps restart it at a lower dose with combination therapy or change to the hydrophilic statin, rosuvastatin, because we know he's a high risk and we want to achieve a threshold under 70 milligrams per deciliter, and he's starting at 167. Okay. And a non-HDL that's 218. So we want to really nail his LDL down if we can. Okay. Ezetimibe is an oral add-on that I find pretty easy to prescribe and very well tolerated. It gives us about a 20% lowering of the LDL like we saw. It's synergistic with the statins. PCSK9, I gave a green check mark to. these are very effective in robust drop of the LDL cholesterol. And now there's no outcome data for this. This is not an indication for it. But by the way, they also lower LPA by 25 to 30%. Is it clinically meaningful? I don't know. But it's nice it's pretty to move numbers, right? But the MACE data on PCSK9s for just LDL-C is remarkable. So, okay, and that's the monoclonal antibodies. Inclisiran is a small interfering RNA PCSK9 inhibitor. It also has a good lowering of LDL-C. Now, in my experience, not quite as robust, and I don't have any specific numbers here, but it's a twice yearly dose. And the barrier here on both of these last two that I'm talking about, the PCSK9 inhibitors, might be injectable. People don't want needles, and costs, prior authorizations. So when we think about all those barriers that Dr. Willard went through, we are being mindful about those here too. Okay, so bempedoic acid, about a 23% reduction in LDL. We can combine them, be very creative. I keep saying that. Bempedoic acid is non-generic yet, so there is some issues with getting it covered, in my world at least. It is useful if they're statin intolerant. Now, bile acid sequestrants, this one's been around for a very long time, and I'm giving it a red X because of its high triglycerides, modest impact on LDL-C, and it can raise triglycerides. And I've seen dramatically raised triglycerides on bile acid sequestrants, and it's very variable among to each patient, right? And really no outcomes data. Now, fibrates, I think Dr. Willard's going to have something to say about this one, but I gave it a plus or minus. It is we use it best for hypertriglyceride over 500. Go ahead. You were mentioning something about these before.
I was actually, yeah, a couple things about fibrates, but also I was going to say the bile acid sequestrants. They've been around forever. And I have to confess, I still have a few patients on them if they are statin intolerant and they want a very inexpensive medication. NHANES data from 25 years ago actually does show some evidence of benefit, outcome-related benefit with the use of bile acid sequestrants. But for the most part, not only do they they raise triglycerides, but they also may cause constipation and other GI issues. So for the most part, we have so many better options now that I think the bile acid sequestrants have really fallen down the
you
list.
agree it's not the best option for Mr. P, correct?
Right. In terms of fibrates, the first thing I always mention is there are two kind of parallel fibrates. One is gemfibrozil, the other are fenofibrates. Gemfibrozil is not a medication that should ever be prescribed along with a statin. It raises the area under the curve for potential toxicity, and so that should be a direct contraindication. And unfortunately, I still see gemfibrozil being used quite a bit. Fibrates in general are cleared through the kidneys. They do have a limited role. Data based from the Jupiter study and quite a few years ago now, demonstrated that in patients who are diabetic and have very low HDL, there may be a role for fibrates. And we do still use them at times, especially for those very severe hypertriglyceridemic patients. Again, I think we have some better options now, but it remains something that's in our armamentarium. Did you want to go back through some of the others drug classes in here and review them a little bit more?
Yeah. Sure. So niacin is the next one that doesn't have much utility, I don't think, anymore. I mean, there are still patients that have been on it for years and years and years. But it can increase blood sugar, can cause liver toxicity and gout. And it might be interesting for us to check his uric acid level or talk to him about joint pains and stuff because he's so sedentary. But so for those three reasons, he's already got elevated liver function tests. He's diabetic, and he needs better treatment than that. It's not going to lower the LDL or impact his lipid panel enough to warrant us giving him hot flashes and so forth. Okay. So the omega-3 fatty acid with the EPA plus DHA combination does have triglyceride lowering impact, but it can raise LDL. And I remember talking to one of the drug reps in my office probably 20 years ago, and she said, oh, well, that one can raise LDL. It was a competitor. By up to 44%. And I said, no. I was pretty young in my career. And then I saw it like really shortly thereafter. So it can robustly raise your LDL cholesterol. So contraindicated, I think, in Mr. P. I don't think this is going to do him any favors. However, icosapent ethyl, which is EPA only, lowers triglycerides, and it does have major adverse cardiovascular events reduction in the Reduce It trial. Still challenging in my world down in Texas to use. It's not covered. It's not well covered by the payer systems and insurance companies, and oftentimes they default back to the EPA plus DHA. So that's something that we really have to be conscientious of and watch. And then these last two are for homozygous FH, the lopidimab and evinacumab, that we're not going to use with Mr. P. Okay, hypertension is yours.
All right. So like we talked about in the first place, all of our patients, for the most part, have much more than just one thing going on. And Mr. P definitely is hypertensive. As we've said, there are 12 main classes of antihypertensives in the United States, 65 to 70 unique agents, and many, many total marketed products, including combination pills. So the question is, how do we categorize and characterize hypertension? First of all, we have to get an accurate reading. And I'm not going to go through all of this. This is taken from the recent hypertension guidelines that have just been published. And it's how to do a blood pressure in an ideal optimal situation. I think we all recognize that when our patients are coming into the office and the medical assistant is rooming them, I love the fact that in my cardiology office, there was a pot of coffee in the waiting room that people could, until we decided to change that people could have a cup of coffee while they're waiting for their appointment. But nevertheless, we should try to obtain as accurate as possible a blood pressure measurement by having a relaxed patient and kind of having the medical assistant take their time in doing this. So, and if a blood pressure is significantly elevated, we want to let the patient sit, relax for a bit, maybe even take the blood pressure again at the end of the visit. But that opportunity to get an accurate measurement is important.
I read an article one time that said if you have a full bladder, it raises your blood pressure an average of 10 systolic, and saying a sentence 4. So there's all kinds of a variety of everyday life that is going to change your blood pressure every second. So
those patients with the full bladders are the ones that were drinking coffee in the waiting room.
Yeah, that's right.
All right. So blood pressure is now categorized, has been for some time. This is the most recent group of levels, if you will, of blood pressure severity. So in the normal blood pressure is considered a systolic less than 120, a diastolic less than 80. Elevated blood pressure, or sometimes what's known as transient hypertension, are systolic pressures between 120 and 129. And then we start getting into staged actual clinical hypertension. Stage 1, systolics between 130, 139, or, not and, or a diastolic of 80 to 89. Stage 2 hypertension are those more severely hypertensive patients, which Mr. P falls into the category of, with a blood pressure systolically of over 140. And I think, if I remember, his diastolic was also elevated higher than 90. So this is the class of medication in the patient that we're dealing with, and probably one that we have to face regularly in the clinic. those situations where we have severe hypertension and hypertensive emergencies are more going to be in hospitalized patients, or make us think about the possibility of secondary causes of hypertension as well.
I like how they describe severe hypertension as asymptomatic, call your healthcare provider, and hypertensive emergency. If you have chest pain, shortness of breath, back pain, numbness, weakness, etc., call 911.
Right.
So that's very good.
Yes.
Okay.
So we know that Hispanic men have about a 50% prevalence of hypertension. And as we've said, this gentleman has a stage 2 um, classification of hypertension. He is obese. One of the things to consider is when we should start screening for secondary hypertension. And we're not quite at that point with this patient yet, but once we get to a situation where we have a patient who seems to be drug resistant, or if they have an extremely low potassium, that's another situation where I do start thinking of other secondary causes fairly early on. But this slide is a nice indicator of when it's appropriate to start looking beyond primary or essential hypertension and addressing some of the secondary causes. They're listed at the top there, so you can go through those. Next slide. Yeah. So where do we start? Well, if we're looking at blood pressure levels only, and the patient meets the criteria that Mr. P does, which is a blood pressure that appears to be averaging greater than 140/90, then we do initiate antihypertensive medications. Again, we always go back to that concept that lifestyle management has to be concurrent with risk stratification that promotes the use of medications as well. So we also want to talk with our patients about heart healthy eating, and I love giving my patients the DASH eating plan, the dietary approach to stop hypertension. I have paper or electronic handouts that I provide for my patients because, especially in certain populations, salt sensitivity is really significant. So we want to address both the lifestyle as well as initiate antihypertensive medication. And then we have to look at the risk-based thresholds, whether the patient has ongoing characteristics that would enhance risk. We don't know with Mr. P whether he has clinical CVD. He has risk factors for it. He has including genetic risk factors. He went to the ER a couple of years ago and had presumably a chest pain workup done. It was not definitive, so we can't say for certain that he has any evidence of clinical CVD, but we certainly need to bring that into the picture. And then that alters our approach with antihypertensive medications a little bit further. Now, in this setting, the other category that Beth has highlighted here, we do have a patient who's both diabetic and with chronic kidney disease. And so we know that that is a substantial enhancement of short-term CVD risk based upon the PREVENT calculator. And in that situation, initiation of antihypertensive medications has to address those risk enhancing factors of the diabetes. And we're going to be thinking more in that situation of using an ACE inhibitor, an angiotensin receptor blocker, and possibly a diuretic. So our goal is to get that blood pressure down below 130, preferably lower.
You kind of already talked to this slide, I think, a little bit.
Yeah, and here are our guidelines for evidence-based therapy. Remember, in most areas, especially in cardiovascular disease, we now have kind of the designation of guideline-directed medical therapy. And those are recommendations that are made based upon outcomes. So we have guideline-directed medical therapy for hypertension and for heart failure. We're moving that direction for lipid management as well, definitely for diabetes. So, but remember, guidelines are guidelines, and we always have to take the clinical situation the patient sitting in front of us into account as we are prescribing therapy.
I think it's impossible to write a guideline for every individual, right? That is appropriate for every individual. So
So how do we customize our antihypertensive therapy for Mr. P, Beth?
yeah, so I think you touched on chronic kidney disease, stage 2 hypertension. I think the angiotensin receptor blockers or inhibitors are going to be our first line therapy with him. You agree?
Mm-hmm. Most definitely. We want to check that microalbumin of the urine as well to see where exactly he is in terms of potential endothelial damage already.
And the guidelines tell us to start with a combination therapy, and we could add the thiazide diuretic, especially because he's got trace edema.
Mm-hmm.
So that's a consideration. I don't think we need a loop diuretic. We need, or a potassium sparing diuretic or MRA at this point. But the cardiac workup will tell us more about how to direct our antihypertensive therapy.
Right. Or if we do find that indeed he has a clinical cardiovascular disease, we're going to be considering the option of beta blockers in addition. And I know you had mentioned in the presentation of the patient that he did sometimes have some tachyarrhythmias. We don't quite know yet what that means. Maybe he was just dehydrated, whatever. But the beta blockers, if there is evidence of coronary disease and they're indicated, they would help with that rhythm as well.
And I'll point out that the choice of beta blocker is super important because there are beta blockers that potentiate weight gain or inhibit weight loss and can raise your triglycerides. And that's metoprolol over, like carvedilol works very well at blood pressure, is more weight neutral with the triglycerides. And so we really have to consider all the nuances among each drug class, that just exactly what we're talking about today. Are we treating one problem and making another one more adverse? So okay, and the other categories, and so I think the take home on this slide is ACE and ARBs, plus or minus thiazide diuretics, amlodipine, but he does have trace edema. We don't really know how impactful that would be, but that's usually an easy to use medication.
Yeah, I'm a big fan of the calcium channel blockers, and generally in the low doses, 2.5 to 5 milligrams of amlodipine, we're not going to see too much aggravation of edema. We did talk about the fact that we want to decrease his overall salt intake, so that might be something that we think about later. But I think, yeah, our first choices are the ACE or the ARBs.
Okay. All right. And now, how many times have you heard a patient say, well, I've been told I have diabetes, but I feel fine. I don't want meds. I don't want to be on insulin. Insulin is a bad word to a lot of people in my world down here in Central Texas. And so I included here the prediabetes and the diabetes diagnosis. I think that a lot of people forget that, when it comes to coverage for medications, this is actually a diagnostic criteria, is a fasting plasma glucose over 126 twice. So when I'm looking at a patient, I'm like, I don't know, their A1C, sometimes it's not not to dig in on this, but there is some discordance with the A1C as well. So I've diagnosed people with diabetes with these top two categories. I don't really do the oral glucose tolerance test. I know they do it a lot in obstetrics. And then this one is only if the person with classic symptoms of hyperglycemia or hyperglycemic crisis is the random plasma glucose. So categories there, pre-diabetic between 5.7 and 6.4, or fasting plasma glucose up to 125 over 100. We're going to talk about that again in a minute.
And so we know his Mr. P's A1C, as I recall, was 7.6.
7, yeah, I think so, 7.6. So he's definitely in the diabetes category. And so when we're looking at consideration of glucose lowering drugs, this is a very busy slide, but just to point out, our guidelines say use metformin first. And a lot of times in order to get an add-on therapy, more expensive add-on therapy, such as GLP-1s, they'll say you have to be on metformin for so long. Contraindicated with eGFRs less than 30. And then, this is what we need to work against, and that's use of sulfonylureas, the thiazide-lipidiones, and insulin therapy that all can lead to weight gain, which is opposite of what we want with Mr. P, right? So, and then the GLP-1s are here. We're going to talk about those a little bit more. DPP-4 inhibitors, cardiovascular side effects has been it's been associated with increased risk of heart failure hospitalization. So I'm just pulling those out. We're going to talk specifically about the top of the guideline here in this next slide. Not this next slide, this slide. So, okay, so let's dive in. So this is just on the side, toxic effects of adiposity. This I borrowed from Dr. Keratin and Dr. Kasibarad in Kansas City. But when you look at adiposity, it has a lot of negative effects, and we really want to minimize weight in this man, right? He's got a BMI of 38. He's probably got MASL with his liver. He doesn't move around a lot. He's on disability. We are going to work up his heart, and he's already got chronic kidney disease. And so all of which are potentiated by adiposity. Do you have anything to add to that one?
Yeah, I was just going to say, if we go back to, first of all, obesity and diabetes are so often correlated with each other. And we know that there is an adipocytopathic atherogenic dyslipidemia profile, which I've learned to say carefully. But
did you want me to
so we know that this high triglyceride, low HDL is a very typical type of profile for lipids in the obese patient who, whether they're diabetic or not, and probably enhanced further with the presence of diabetes. If you go back to the grid that you had on the last slide, you've highlighted here the drug classes that foster weight gain. And it is really challenging to use those medications in the setting of a patient who is already trying to lose weight. The other thing I was going to add is sulfonylureas. Hopefully we are moving more and more away from using them. There actually is evidence that there is some cardiovascular risk associated with sulfonylureas. I would like personally to see them disappear. But the thing is that they are cheap and readily available. And so I'm sure all of us still have a lot of patients who are getting those, especially in our older population of patients. So those are the ones we need to watch for hypoglycemia in.
Right. And it actually should be red boxed over here on the sulfonylureas that cardiovascular side effects increases cardiovascular mortality and syncope. Yeah, so good.
And the fantastic class of drugs that we have now available to us are the GLP-1 receptor agonists. And I think you're going to get more into that with the next slide.
And I'm going to pause here one more time too and call out sleep apnea. I would definitely want to screen this gentleman for sleep apnea, which can make it really hard for him to lose weight, make him gain weight, and make sugars higher if he's not treated, worsen the diabetes, make it harder for us to help him control the sugar, the diabetes numbers. And then you're tired. He's not going to want to move around. It just makes everything, it compiles everything in a worse fashion. Now, this is actually, I put this in, I don't know if this is just rudimentary mechanism of insulin associated weight gain. I have a lot of patients that look like Mr. P that are started on insulin without being on the other ones. And I don't like that for type 2 diabetes, right? So the insulin therapy increases glucose uptake and anabolism, reduces glucosuria, so there's fewer calories lost, and then hypoglycemia risk, of course, compensatory eating. In a nutshell, you get positive energy balance. They're eating more, they're retaining more calories, they're gaining weight, so more fat storage and more visceral adiposity, which you had mentioned with the adiposopathic dyslipidemia.
Adipocytopathic atherogenic
That's,
dyslipidemia.
that's
Yes.
quite a mouthful.
Uh,
All right. This I used when I presented at Texas ACC on GLP-1s and cardiac benefit. Now, I'm not I don't need to necessarily go into all of this in detail, but the GLP-1 agonists are accumulating so much more and more benefit. I mean, what I always say, what happens when we eat less, right? We have improved lipid disorders, we improve fatty liver, reduced risk of heart disease and kidney disease, delays progression of diabetes, reduces the risk of diabetes in pre-diabetic patients. In fact, I mean, we have the SELECT trial that wasn't just pre-diabetic, but lowered diabetes incidence by 73% over 4 years. And we've got the SURMOUNT-1 trial that looked at pre-diabetics, 94% over 3 years were prevented from becoming diabetic. And if they stopped drug, it fell to 88%, but really good, strong data there. We know about the weight loss and reduces inflammation. They're looking at these medications in their benefit for dementia, substance abuse, and cancer risk. And I've actually told patients this when they're trying to quit smoking or quit drinking or something like that. I'm like, we're starting to see signals that this medication is going to help, and maybe they're going on it for diabetes, but kind of puts it in their mind, and they said, I didn't want a cigarette after I ate or something. So it's an art, right? Medicine is just as much as an art as it is a science.
it is definitely an art.
Yeah, so this is just kind of a summary slide for the type 2 diabetes drugs that benefit beyond glycemic control. So you see the SGLT2 inhibitors. We were talking before how our cardiologists are really prescribing this
They
medication
are
now.
embracing the SGLT2 inhibitors, especially in their heart failure patients.
The data is amazing. Yeah, lower heart failure hospitalization. It helps prevent kidney disease progression and cardiovascular events. So, I mean, can't argue with that, right? As long as the barriers work with us.
And I
GLP-1
think,
receptor.
well, I think we always have to remember that patient education and that discussion about what these medications, their benefits and their risks, because for both the SGLT2 inhibitors as well as the GLP-1 receptor agonists, I have had patients and colleagues describe they're not for the faint of heart. In other words, you really do have to educate the patients in terms of timing of when to take them, potential side effects, how to deal with those side effects, but they can be amazing drugs.
Right. And I think working with, pulling in the multidisciplinary team when you're starting someone on a GLP-1 with a dietitian, there's definitely ways to change your eating habits to minimize the impact on nausea, vomiting, constipation, that kind of thing.
Right.
Yeah. And then the dual GIP GLP-1 has emerging cardiovascular benefit and potent weight loss. Really good data there. And metformin we talked about. So this is just kind of a summary slide. The last 1, 2, 3, 4 really are glucose control only. However, the pioglitazone really can have robust effect on lowering triglycerides. I don't think that's an indication for it, but that's one other benefit from that one. But the risk benefit ratio really needs to be considered in using any of those, and based on the severity of the diabetes and control. Okay. So I think we have a good handle on drugs that we would choose for Mr. P. I got this quote off of LinkedIn this morning. Every decision you make, every conversation you initiate has the potential to change a patient's journey, and there's a ripple effect to everything we do. So I hope this helped weed out some of the noise with all of these different classes of drugs and these different medications when we're approaching a patient such as Mr. P. Dr. Willard, do you have any more pearls before we look at the chat?
No, I do think that this is a great quote. We have to look at our entire patient as they're sitting in front of us and help them understand the pathology of their disease as well as the choices that we are considering to be optimal. and make those shared decisions because we're going to promote adherence to a patient's medication regimen when we do that as well.
Okay, I don't know how we can see if we can see the chat here.
I have the chat up. I don't see any
Oh.
questions in there right now. Deanne, can you help us with that?
I do not see any chat questions.
Okay. And I was going to put up our thank you with our, I hope to see a lot of us. Many of us can make it to the clinical lipid update in October in beautiful Scottsdale. Somebody raised their hand, it looks like. Oh, I just got a text that the chat is disabled.
Oh, no.
Let me see about getting this activated.
But at the CLU in October, we've got Bob Eckel, Dr. Eckel from Denver. He's a pioneer in I'm a fan of in the lipidology world. We've got a lot of really great speakers. There's a session on dementia and um, I'm sorry, I'm watching this pull up too, the link between lipids and dementia. This is a hot topic right now.
There is a women's health session as well when it pertains to cardiovascular disease and dyslipidemia. So a lot of really great topics and very good speakers.
Great speakers and just great people. I leave there so energized from these conferences. It's small enough to embrace the company and robust enough to learn a lot and take ready to use information home with us.
Okay, so I see now that everybody is able to talk and everybody is able to chat. Apologies about that. So if anybody has any questions.
Thank you, Carol Kirkpatrick. It's good to see you on here. our
Yes.
dietitian. And so much more. Thank you, Lauren. Another dietitian. Yeah, we love our dietitians.
We definitely do.
Yeah. Okay. Oh, and hi, Rhoda. Thank you. All right. I don't think anybody has any questions, but I don't know about you, Dr. Willard. I was going to put my LinkedIn on here and I never did, but
there is one question here. Excellent presentation. Why do we still keep insisting on using metformin? Partly because of the impetus to do so from our health plans and the challenges with getting prior authorizations for other types of medications. But for the most part, it is still a strong consideration in the patient who has relatively intact renal function, avoids, for the most part, hypoglycemia. So, 5 years from now, are we going to be using metformin as much? Maybe not. But for the moment, it's still on the top of all of our guideline related algorithms for diabetes management.
Yeah, I was listening to it was a podcast or something with Dr. DeFranzo, who is a leader in the diabetes world in San Antonio, Texas, and he had commented that the top 3 most impactful for diabetes and the do no harm kind of thing as well is GLP-1s, SGLT2s, and pioglitazone, but in the right patient.
Right.
So you got to be selective with the TZDs. All right. Well, thank you everybody very much. Dr. Abdullah, thank you for your question. And I know we're connected on LinkedIn, and so it's good to see you here. All right.
Thank you everyone for joining. Hope you've enjoyed.
Have a good rest of your week. I'm going to stop sharing.